Morning, guys. So yeah, I thought I was telling Jen and Rob that maybe we can do two separate sessions. This one we'll go over MCS overall, and then we'll do a separate one with cardiogenic shock. Hopefully I'll have some data from us to share and an algorithm of how to, and I'd like to do that together, right? So on how to approach these patients as a group. Um, Nothing to disclose. So, you've seen this already. So this is pretty old now. The use of this devices have grown exponentially over time. Now, academic cath labs are dealing with more heart failure patients and therefore the need for more mechanical circulatory support, especially catheter-based therapy like peripheral ECMO here and Impellas. And there's a significant drop in the use in balloon pumps for ACS. And that was followed with a increase in balloon pump after the UNOS criteria changed. So now you can be a UNOS 2 for a heart on a balloon pump, similar to a 5.5. So that rose the use of balloon pump for heart failure. So this is what I
Was that? On Davila,
no, this is like NCDR administrative data of the use of MCS across the nation for AMI shock and from heart failure shock. I think that the point of this slide is just going up, right? So 5.5s, VA ECMO, cath lab based ECMO, and CPs. So I think what helped me a lot about these devices is to use this equation. So it's the hemodynamic support equation. What are you trying to achieve when using one of these devices, and how can you measure those surrogates to help you inform your decision making, right? So are you dealing with a pure coronary issue, right? So someone with triple vessel disease waiting for a CABG, you should use a device that it's very good at perfusion the coronaries, like your balloon pumps, right? Are you dealing with significant circulatory support, right? So extremities, like are you dealing with complete circulatory collapse requiring not only heart support, but also complete circulatory support, or are you dealing with unilateral or biventricular support? And these are the surrogates that you can use in the room or before the patient get into the room to make you help that decision. Here are some of the indications for these devices: high-risk PCI, AMI shock, heart failure shock, post-LVAD RV dysfunction, or straightforward RV dysfunction. You can divide these devices and based on anatomic support. So are you dealing with the left side of the heart? Are you dealing with the right side of the heart? Or are you dealing with both sides of the hearts? And here are your devices. Or you can use how do they work? Is it centrifugal flow or pulsatile flow or axial flow pumps? And then, oh, I lost my slides here. Are inside the body or outside the body. So this is just to classify them based on anatomic support or how they work. Here are probably some of your board questions. So the indications for MCS and more importantly, the contraindications. I don't think I need to go over this. So what I'll try to do is every time I give this particular talk, I'm able to go over balloon pumps and a little bit of Impellas and nothing on ECMO. So I was thinking we can just go the opposite. So maybe start ECMO, Impellas, balloon pumps, and then if we have any questions, we can go back to these things. These are just slides that I've been putting together over years. So I'm not gonna touch on everything. So any questions about balloon pumps right now? How do they work? How to interpret the waveforms? How to deal with alarms? Right? They've been great. They've been around for a while. They still have some role in our cath labs and our ICUs, but maybe we can jump ahead and go down to. So these are all balloon pumps waveforms and indications, contraindications, and all that. All right, so why don't we talk a little bit about microaxial flow pumps, aka Impella devices for now. I mean, I was just in a meeting and they have 8 in EFS stages. So there'll be a lot of these things coming out, granted, if FDA has approved them. These are microaxial flow pumps. So they are a translation from LVAD medicine into percutaneous approaches. For our lab, you'll be seeing the Impella CP, right? And the 5.5s and our ICUs. So the Impella CP, as you know, is a 14 French sheath. It's a 9 French drive line, and has an inflow cannula and an outflow cannula and a sensor distally that helps you with waveforms and whatnot. And then the 5.5, it's a 21 French surgically implanted for now, using graft and in subclavian access. Some of the hemodynamics effects of these pumps. So these are PV loops that I used to do as a general fellow, and pretty much we just turned the device on and had a catheter in the LV looking at different time points and pressures, and see how there's a significant reduction in both pressure and volume when you turn on these devices here in the bottom, and that translates into reduced myocardial oxygen demand and reduced LV pressure and volume and circulatory support as well. So when going back to the hemodynamic equation, if you're looking at those 3 boxes, it provides circulatory support and LV unloading, right? As far as we know. And this is that graph that pretty much how LVADs were invented, and they were translated to the cath lab. This is called the HQ curve, and so it's a relationship between the pressure head and between the inflow and the outflow of a pump at the flow rate. What you need to know about these devices is that the flow is dependent of 2 things. So it's proportionally dependent to RPMs, right? So the fastest this thing spins, the more flow you get, right? So common sense. And then it's inversely proportional to the pressure difference between the inflow and the outflow. How do we translate that into our cath lab? So for these devices, you need preload and they're afterload sensitive. So if you think about someone in shock here in the bottom right of this curve, the pressure difference is higher and therefore, or is lower, and therefore the flow that you will get from these devices is higher, right? Compare that to someone who are you put in an Impella in for, distal left main bifurcation or last remaining vessel, whatever, but with a stable current or blood pressure to begin with. At that point, your flow is, although the machine will tell you that you're flowing at 3.1 or 3.5, your effective flow, that's calculated, right? That's only calculated. Your effective flow depends on your afterload. So at that point, whether you are supporting the patient or not, it's probably not unless you get into troubles, right? And then you need preload, right? So you need preload just like every LVAD. And that's when we get into the suction alarms. These are some of the big stuff that we're doing. So the 3 boxes, circulatory support, LV support. Now we're trying to look and see if there's any coronary support from these devices using PET imaging. Some preliminary data showing that, yeah, sure, there is some coronary support. And this is another PV loop that we just did, looking at the same thing now at different speeds and looking for a threshold of what should be your performance level. We will never use an Impella P2, right? So that's when you're about to disconnect. But the question is whether, P4 and P6 and P9 will provide similar support or equal support, and you'll try to reduce the risk of complications, mainly hemolysis. Right? Okay, so why don't we go over the alarms? And I think this will be the most important part of the Impella talk. This is your console, right? So why don't we go over these things together? So what's red here, Robbie?
Your aortic waveform.
Mm-hmm. And how do you get this?
There's a sensor in the outlet,
Okay,
and it checks the pressure.
perfect. So it's a sensor derived, just like your balloon pump, right? What's the,
Oh,
how do you get this?
I don't think there's a sensor.
Good. There's no sensor there, so it's calculated by the console using AO pressure and the motor current. So whatever pressure, whatever oscillations in the motor current happen. And then you have the motor current. This is pretty much how the axial flow pump is spinning, right? Then you have bottom left, you have what? Flow, again, calculated, just like an HeartMate 3, just like an Impella, just like an LVAD. And then the perch, what's the perch for?
To keep the system
Clean.
like from rusting or just
The impeller,
and
maybe? No, not really.
Anybody? So it's fluid that gets it comes out right before the
It's-
actual outlet to prevent clotting of the impeller. And
Yes.
so that's all it does, but it's very important because if you have any issues with this, it clots relatively quickly. I saw a couple in fellowship that get clotted, and it's pretty bad. And then you have your control, right? So you have the thing that you push, and then you can use this menu, right? And the most important thing will be alarm review, performance levels, and your overall menu, right? Okay. Any questions about your normal console here? No. Okay. What happens here?
it's in the
Pull it, yeah, or
no
no.
something.
Okay. So, and can you tell us why that's the case?
You don't see the motor current is flat, so it's not like really doing.
Okay.
There's no gradient being produced. It's just in the
So the LV and AO are superimposed, meaning that they're both seeing the same thing, and that's the aortic pressure. And yeah, the motor current is not feeling the LV going up and down. So that's your telltale sign. You have three colors: red, yellow, and gray. Red needs immediate. It's an emergency. Needs an immediate. Needs to be immediately addressed. Yellow is urgent. It needs to be addressed quickly. And gray is a resolved alarm. So what do you do when this happens?
that I cool.
Okay, good. You'll confirm that it's not in the LV. What else?
Drop down to P2.
Then? Are you reading that? Yeah, sure.
I think. No, I wasn't reading. Yeah, so it says what to do. Reduce to P2. Sometimes you can get it back in.
Where? What do you do? You're in the CCU. What do you do?
So you have your adjustable repositioning sheet. Get a stat echo, drop to P2, confirm, and you can unlock it and position.
They also have that program, that software that's like programmed in the Impella console, right? That you can just like a smart assist repositioning software that just tells you to do it without echo. I've never done it, but I don't know. Do you like it? Is it?
So I think what I will propose, and this is part of the proposal, is that we will never reposition this at the bedside. Okay. This is something that should be done in the cath lab under fluoroscopy. There are some programs that do it at the bedside. The concern being, and I'll show you one of the few Impellas that I've done here. In the unit, the patient's been turned, and then I get called. You know, this is what we're seeing. So I'll show you some of the, and you saw that case too, right? So I'll show you. Okay. So what's going on here conversely? So you get superimposed LV pressure, both in the aortic sensor and the LV calculated thing. So this is something that you could do at bedside, right? So this is different. So this is that case, right? So we do someone in shock. We did a circ, put a swan in, remains in shock, left the device in, and probably a couple hours later, we get called that the Impella console is alarming. If we can just go to the bedside. So the Impella console just showed an aortic tracing. We can confirm that here. And what we said is, all right, let's go to the lab. And the thing is, if you push this, and it's happened, if you push this, the Impella can kink so on its own, and that's a problem. Then you cannot even get it out. Then you have to start snaring things or sometimes surgery. So, and it's not easy to get it through the aortic valve because it's bulky. You got a lot of slack here, and then it starts to kink. So it starts to kink right at the outflow every time you push. So what we did here, I don't think this plays. So, oh yeah, it does. So what we did here is we use some structural techniques. So we rewire the side port. So, right. So rewire the side port and use a stiffer wire to try to cross the aortic valve. And that
Like
once,
implants? Or-
yeah, that's an implant. And then once we crossed the aortic valve, that wire was helping us. I'd like to think it was helping us to keep the valve open. And at that point, we pushed the Impella down.
So the wire is pushing up against that valve.
The wire is across the valve in the LV and pushing you outside, or at least like
Kind
I
of
think
like a
that,
buddy wire type.
right,
thing.
like a body wire. We tried to push that without the wire, but it was starting to buckle. Like Josie was like, whoa, stop.
Does that, does the wire give some, structure to the catheter so it's less kinkable
Not really, because it comes out
before the.
before the actual impeller.
It's 035.
It's an 035, yeah. So that was a nice trick. And then we had someone give cath
I would
compliments with
say that
snaring.
you're not home free just because you got that wire across the valve.
No,
Definitely.
but it did make it, I mean, I want to think it made a difference because we couldn't get it just by pushing and pushing and this was the first try with the wire across. So,
But also on fluoro, you're seeing it, it's about to kink.
Yeah,
Yes.
that's for sure.
Blindly.
and that's why we shouldn't do it at the bedside. So you get an alarm, page, call the attending, goes to the lab, right?
For AO.
For AO.
Yeah, for LV, it's okay.
Yeah.
Because that's,
Pull them back.
But you don't want to.
Assuming you don't.
We
wanna
can
go
talk
back
about
too
that.
much.
I think at the beginning, like I wouldn't be opposed to even pull it back in the cath lab.
Yeah.
Now there are logistics about that, taking a room, transfer, but
Overnight
I
activation
think-
just for that.
right, I think especially at the beginning, doing everything related to these devices under fluoro and imaging guidance, it's not wrong. Let's put it that way.
Carlos, the case reports of snaring to
Yeah.
push it back in that I've seen
Mhm.
have been radial.
Mhm.
Do you think it could be done as easily from below?
Yeah, I think so. I think I think as long as you get a good snare there, I think so. The couple of snares that I was involved with, it took us a while. So that makes you wonder, do we really need the support? Because if you're stable there for an hour and a half, well, you snared these things, and then it becomes an ego battle, But I don't know. I think it's a neat technique. Like even at that point, I remember one of those that we just couldn't get it and just put another Impella in. That's
Like the dreaded combo.
Right.
Or the situation.
right. Okay, so yellow alarms. The most important one is suction alarms, right? And suction alarms, just like an LVAD, your differential diagnosis is pretty easy. It's 3 things or 4 things. Impella positioning, number 1. Are you against the mitral valve or are you entangled and you're getting suction? Other than that, it's these 3 things. That's all you need to think about.
Carlos, can I ask a quick question?
Yeah, sure.
So with the new Impella, if in a situation where it's in the aorta and you can't get it across, you can now rewire the sheath, right, and not lose access, whereas in the past you couldn't. Isn't that correct?
Yeah, this wire that you see here is through the repositioning sheath. So yes, you have
Right.
access.
So you could pull it out, put a new sheath in, and put a new Impella in. It's just the cost of the Impella. It's not a new access site, correct?
Correct.
Like in I guess the question is, right, if a patient's crashing and you can't push that right across.
Correct.
It seems to me the quicker way to bail yourself out is to say, okay, let's rewire this, put in the sheath and put in a new Impella, which is probably going to be a lot quicker than a more complex, snaring it, doing other stuff, which you, I think, used to have to do with the old Impellas where you couldn't rewire the sheath.
Absolutely. I think that was for this particular case, we were prepared to do that, but
Yeah.
we're stable enough that we were able to get it
Yeah.
down. But yes,
Yeah, just
absolutely.
as a thought, like so people
Yeah.
know what to do where if a patient's crashing and you have the impeller and it doesn't push across, it probably is better to just put a new one in.
Yes.
And if it's kinked, you can just pull it out or,
Sometimes that kink it doesn't get you pulled all the way down, and that's when you need to snare to straighten it out,
Exactly.
and then that's when you get in trouble. So, okay, so suctions again as just like a suction alarm from someone with a heart rate 3. There's 3 things. Are you bleeding from the groin?
Yeah.
Right? Is your RV not working? So the indication from the Impella wasn't the right, or are you dealing with pericardial effusion? Those 3 things. And out of those 3 things, most likely is bleeding, right? And then the calculated.
Carlos,
Yes.
can I just one thing, and I don't know if you're going to get to it. So, because we just had this the other day. So I know more and more people are getting used to pre-closing. But one of the nice things about the pre-closure is that when you have the Impella in, if you're bleeding around that sheath and around the groin, you can take the long pre-close and pull it taut, which will bring the knot down onto the top of the Impella. You don't want to lock it, but you can pull that down and that will often decrease bleeding. So we did that over the weekend in an Impella that had been put in. They hadn't been pulled up to sort of cinch it down a little bit there to decrease the bleeding. But if anybody doesn't understand what I'm saying, I'm happy to show. But just as a way of decreasing sort of the bleeding that can occur around the groin and around the sheath.
Yeah, we'll talk a little bit about that as well. So okay, and so also if you want to get nerdy about it, the LV tracing has some surrogates of early suction, right? So for example, this LV tracing here shows a negative diastolic here recover. So if it's below the baseline with a sharp motor current, this could be suggested of RV failure or hypovolemia most of the time. So if you've seen this root square sign here, this is probably an Impella that's starting to see low. You used to see with hardware LVADs that had a console, you'll see this thing. So this is pretty much a translation from an LVAD console. Then when you have the systolic blood pressure is lower than your AO, and then there is negative diastolic pressure that doesn't recover, this is likely in positioning alarm, but you'll get a suction alarm. Regardless, what you need to do here is you'll get a stat echo, right? You check your hemodynamics. If you suddenly now have an RA of 1 or something else, you're dealing with preload and either bleeding or something else. How to assess Impella positioning. Very important that you know your landmarks in echo, both as a CCU fellow or an interventional fellow, because you're the one getting called to the bedside, right, to look at these things. And if you're getting called, someone has in their mind that the Impella is moved. That doesn't necessarily need to be the case. So you need to look at these landmarks very clearly and identify them so you can decide whether it needs to go to the lab or being pulled at the bedside or whatnot. So you have your pigtail distally here, and then right after the pigtail going proximally, you'll have a teardrop, so something that's going to look darker before you see the actual inflow of the cannula. You're supposed to measure right at the teardrop into the aortic plane. So this is your aortic plane, okay? And this is your teardrop. And I think this used to play, but it's not playing anymore. When it plays, you'll see it much better. Also, you need to see the relationship between the pump and your anterior leaf flow of the mitral valve. Are you entangled or are you underneath the mitral valve apparatus? That can happen, and that's where complications happen, i.e. suction or more hemolysis. It's important that every time you reposition or you finish a case with an Impella, you deal with the slack in the system. So you have the drive line, and at the end of the case, you got to make sure that drive line gets straighten out, and also you have to lock the TUI at the repositioning sheath to prevent movement of the device. Also, every time you're trying to reposition this device, you should drop your performance levels. P3, P2, I don't think it's safe, but P3 to avoid any overt hemolysis. And this is the hemolysis data. This is from animals. So pretty much leaving the Impella running forever and see what's the based on receiver operator curves, what's the performance levels at which hemolysis happens the most. And it's around P6 again on animals. And so if you see me using these devices, I rarely go above P6, based on, not human data, but I think it's helpful. And honestly, the difference between P6 and P9 in terms of support is not that much. And if you need it, you probably need to upgrade to a higher level of support. So growing management, I think John talked a little bit about this. But this slide talks about patients coming from, for example, if I'm on call at Greenwich and I'll put a balloon pump in, but we think someone needs to be upgraded, what needs to be done? So the first thing that you should do is get a new stick. So do not rewire the balloon pump and deal with that groin. You get a new stick using ultrasound, fluoroscopy guidance. And then once you put an Impella sheath in, this is probably the more scary part of the procedure, is getting this peel away sheath out. The next iteration of Impella will not have this peel away sheath, but we're still dealing with it. And it was not uncommon to get transfers with Impellas with the peel away sheath is still in place. And this is what happened. You have a dead space between the driveline and the peel away sheath, and that clots pretty quickly. And then your risk of limb ischemia goes way higher. So this is.
Why do you think that you have to, why do you always need a new stick? Like if it's coming from L&M and I did the stick and it was sterile and everything looks perfect when it arrives there, like what's the?
I think the rewiring and taking out the balloon pump can get you in troubles. Like let's say the balloon doesn't come out and you tear the arteriotomy and then you put another sheath in. I don't know what's going on there. So yeah, this is something that we could review together as a group.
Pulling out a balloon pump, but let's say the patient has like a 6 from just a sheath in.
Yeah, then you can take a picture and upsize. Again, this is not IFU. This is something that, based on experience and bad stuff happening, the group, and we can easily review this together and say, yeah, I'm on Greenwich, I left a sheath in, and take a picture and just
It
upsize.
might be helpful to like, at Greenwich or at L&M, put a 9 in instead of an 8, because then you are able to like pull it out more easily, the
Yeah.
balloon pump, and then you're less likely to have that issue there.
We can do that. What I've been doing, and I asked Chris if I could do this. Like if I'm dealing with someone with shock, I'm not putting a balloon pump in because it delays transfer. So I just try to fix the vessel and get them out. And so I think, hasn't happened that much, but it's happened.
Sometimes you think the LED is closed, it's early, you think you're gonna be okay, you open the LED, you put the balloon pump in, but then 2 hours later, you realize you're going the wrong direction. And it's every case is a little
Yeah.
different. But that's what I would do is, I think the 9 makes
Yeah.
sense a lot of the times now with the current balloon pump.
Yeah,
And like, it seems to me, if you can slip it through,
I think that would.
I think we can do that. And then so groin management for these devices, even in the setting of shock, I think for those who do a lot of groins, which is all of us, I think if we can get 1 per close in, it's a lot. And if we can get 2 of them, it's perfect. And then you should always check distal runoff, and that's when you decide about distal perfusion catheter. So DPC, there's a lot of actual pretty neat research going through that, and in terms of active bypass or passive bypass, do you connect this side port to the Impella sheath, or do you get a contralateral access and do fem bypass? So pretty much what they're doing is like FFR. So you get a wire distally and then a wire proximally and see what happens when you occlude the vessel with an Impella sheath and how much perfusion you get if you're connected through the Impella sheath or if you get another femoral access as a donor to the ipsilateral side. Again, this is all research, but the problem with the Impella sheath is it doesn't provide enough flow through that side port to perfuse the leg. So some of the places are doing fem donor to recipient, a bigger sheath on the left, and then your 6 French in the SFA on the right. But I think at the beginning, what we should try to do is, let me see here. So here's that what John was mentioning, and this is actually post-closure. So this was right after the side port was available and comparing what happens to groins if you just hold pressure, right? Or you do the post-closure technique. So clearly, if you're able to close it with the post-closure, all the complications decrease significantly compared to manual hold. This is post-closure. What John was referring about is pre-closure, right? So you get your 6 French, dilate a little bit, put a perclose. If you're in a rush, you get a single perclose, which is enough for this. But ideally, you get 2 percloses in. And one thing I'll propose for the algorithm is, this should be a 2 attending case during daytime, right? So you should have the fellow prepping the pump, purging the pump, and then you should have 2 attending. So femoral access and pre-closing, all that happens relatively quickly. This is the post-closure technique. Post-closure technique meaning that you didn't pre-close and now you're trying to remove the pump, right? And this is through the actual peel away sheath before the side port was available. So what you do is you get a wire in. So you get a wire, and then you get 2 wires in, 2 035 wires in a body fashion. And then you get a 7 French dilator or bigger in one of the wires just to add some space to the arteriotomy. On your other wire, you get a perclose, right? With the dilator in place over the other wire, and you deploy that first perclose, you cinch it down, and then you exchange. So now you have a suture, and then you get a second perclose over the other wire, and you cinch it down. And it wasn't as clean as this picture, but it worked pretty nicely, and it's helped a lot. And now there's a new technique. I show you that, Jen, where you use the actual. So you wire the side port,
Yeah.
right? And then you lift the wire, you lift the drive line in, deploy first perclose, you take it out, and then you deploy the second perclose. That one I haven't done.
But this should be like second to just doing it up front.
Yes, no. Ideally, it should happen up front. Yes, this should be.
Cause I just don't think I've done like similar techniques to this before, and I just don't think it works as well.
Yes, I think I completely agree with that. Pre-close is the way to go, if we can. This is one of the cases from here as well. So always, once you have the sheath in, just try to document antegrade flow, right? So this is the 14 French. We're just injecting through that, and you can see, I mean, it's not the greatest flow, but it should protect you from limb ischemia. And if not, you know where your SFA is, and if you need to obtain distal perfusion catheter or not.
One question for the group.
Yes.
Can you hear me? Hey, thanks, Carlos. When you do a pre-close, any concerns about the device? Obviously staying in and having the stitches in. Obviously for however long the patient has the Impella in. After they leave the lab.
Yes.
Any data or concerns about infection or anything like that?
Yes, there have been reports about infection through the sutures, and I'm sure you guys have seen a couple of pictures. Some operators using a side port of a sheath, so they cut that plastic and then they cover the sutures with that, and they use a 3-way to cover it. Honestly, another thing that I'll propose is that a CP shouldn't stay in place for more than 24, 48 hours. If that's the case, you need to be upgraded or downgraded to nothing. So FDA approval for CP is up to 7 days, but if you're still struggling at the first 24 hours, 48 hours, we should talk about upgrade or withdrawal care, because that's where one of the issues that they published recently, the golden 24 hours for shock at least, and the importance of upgrade within 18 to 24 hours. But yes, so if you leave it in place, there's a risk of infection. You can cover it with the side port of a sheath, and I usually just give antibiotics and all these patients as well.
Okay, thanks.
I saw one groin infection and it's it needs surgery. It's
What do
nasty.
you give for the antibiotic?
Stuff.
Okay.
Yeah.
At the time of when you put it in.
At the end, I always give yeah,
For all of these.
for all of this. That's zero data.
Sure, I do stewardship if I have something to say about that.
Yeah, everyone's jumping around. Yeah,
So,
I
yeah,
dropped the dilator. Just,
exactly,
yeah. Danger shot, we'll talk about it later. You guys know the new evidence about this and how we're trying to adopt some of these practices. I have this case because it really struck me when I was a fellow, and I always presented in this meeting. And so this is someone that came in with a large LED, never forget, large LED wraparound STEMI. And here are the hemodynamics. Since we have a new batch of fellows, what do you guys think about these hemodynamics? So you have an AO and then a SWAN down here. Is the patient doing well?
No,
No.
aortic pressure in
Okay.
50s.
Pretty sick, right? And then so something happened. We did something, and here are the hemodynamics.
You're putting like RV support.
Okay, can you tell me how you got to that conclusion?
So there's, RAP uncoupling, which help guide us there.
Mhm.
And then you see a sudden increase. Obviously somebody's coming from the RA that's helping to increase that forward pressure.
Mhm.
So either in fluids, which probably not, possibly, but other would be RV support.
Excellent. So yeah, that's the case. And so if you think about it, you're the operator, you get an LED that is occluded and someone who is in shock. Probably you'll do what type of device without looking at this?
For RV support.
No, without looking at this. So
Yeah, RV support.
right, so you'll put an Impella CP, right? So what would happen if that's the case?
We don't have anything for that kind of forward pressure. Everything's kind of back loading. Yeah.
So you'll get what type of alarms?
Suction alarms.
So you get suction alarms, suction alarms, suction alarms. And interestingly, they just published a new analysis from Danger that those with as a subgroup analysis of patients that had a lot of suction alarms and how they works. So it makes you wonder how many of those had RV component to their shock. We were always told that any acute MI shock, it's biventricular shock to begin with, because you have septum involvement and whatnot. So I think that this is a really nice example of how hemodynamics can guide you. And when I saw my attending asking for an RP Impella for this case, I was like, I was literally shocked about it. So these are some of hemodynamics about that case. Initial RA pressure pretty high, very low pulsatility. Wedge was relatively low, and these were the hemodynamics. So shock, PAPI less than 1. So everything consistent with cardiogenic shock. And then this is what happens after right-sided support. You'll see improvement in right atrial pressure. Wedge pressure actually goes up now, and PA sat gets better. Everything gets better. And
Carlos, on a couple of slides back on the waveforms, on this one, why is it arrhythmia? Why is there so much alternance in the AO pressure here?
looking at the EKG, I don't think that was the case. So this AO tracing is after you get support. So, maybe there's some inconsistency about preload coming through there.
Is the patient intubated?
I don't remember. I don't.
Yeah, it's the wedge is so low.
Yeah.
I mean, they might not have.
But you'll see this nice uncoupling here. So now you have continuous flow. You don't have pulsatile flow. So you have continuous flow here from the impeller. And that's probably why you get some alternance here. But it's a significant increase, sudden increase in pulsatility. So yeah, this is about biventricular shock. We can talk about this when we talk about shock. But now, so ECMO, I really wanted to talk to this crowd about ECMO. Recently at the retreat, we heard that there are a couple initiatives about increasing ECMO and how critical care and city surgery are discussing these things. I do think both heart failure and interventional cardiology should be part of those discussions because there is growing evidence about ECMO in the cath lab, the utility and new cannulas that are designed for interventionalists and whatnot. So first of all, we need to understand how does ECMO work. So can someone walk me through this? Jan, your critical care.
So, I mean, it depends on the circuit, but typically the RA goes to the oxygenator. There's exchange of O2 rich heme, and then it goes into the A circuit, which is typically in the I don't know where they typically put it, like from A to AO, and then
So yeah, it's usually a FEM system for us. From surgeons, it's usually central, but for us, it will be FEM to begin with. And so you draw blood from the right side through a big cannula, usually 25 French, that goes into a pump and an oxygenator and then goes back into your arterial system retrograde. So meaning you're pumping blood through the femoral artery. If you think about that, so you're pumping blood against the heart, right? But you're supporting the circulation. And this is what happens to preload, to afterload and volume when that's the case. So this is the circuit is off, and then as soon as you turn it on, there is significant increase in your afterload. And that's very important for management of these devices. VA versus VV. VA bypasses both the heart and the lungs. VV bypasses the lungs only, so it's venous. Very important to have multidisciplinary approach for these devices. In terms of providers, these are all the providers that should have some sort of interest in this type of MCS, and then some support in terms of ICU and of course, nursing and whatnot. Okay, so let me see what's this. So this is another hemodynamic tracing of one of those cases. So what's going on here?
Yeah, we rise in EDP.
Okay, can you walk me through that?
So you're not venting the LV because of the retrograde flow. And that's why we're seeing this rise in
Okay.
EDP.
So everybody understand that. So now that you're pumping blood against the heart, this PV loop is being translated into your LVDP. So now you're rising LVDP, therefore LA pressure, therefore wedge pressure, therefore output and index and whatnot. And that's where the concept of venting, that we'll talk a little bit about that. Other things that I think are important for our crowd is arterial cannula size. Every time we have an M&M, someone crash an ECMO, I only ask what question is, what's the size of the arterial cannula, right? That's always the question I ask, because surgeons are used to cardiopulmonary bypass and long surgeries and whatnot. And so the default is to go with a 23 arterial or a 25, which are massive sheath for the arterial tree. The question is, for someone who's crashing, does cannula size matter? And if so, what should be your default for percutaneous approach for ECMO? Then we'll have the ECMO flow index that you need to understand like in the cath lab, what I'm trying to say is like, don't think like we're just interventionalists. We don't need to care about these things because this is what makes outcomes. And then the arterial partial pressure of oxygen. Oxygen is great, so why don't we give them a lot, right? So are those things important for these patients to survive a crashing ECMO round? So the balance between a small cannula and a small cannula is anything below 15. So 15, it's usually your starting size for an arterial cannula. And they have 17, 23, 25, 27. So is it bad to use small cannulas? So the good thing is that less cannula, associated complication, less limb ischemia, facilitates decannulation and upsize. And the bad is that it will make you think that it limits circuit flow and therefore end-order perfusion and also high pressures in the circuit and therefore hemolysis. So that's been looked at looking at ELSO, largest registry of ECMO, looking at different cannula size and then trying to adjust to as many variables as possible. Again, observational retrospective. But in terms of perfusion, using a smaller cannula for the first 48 hours doesn't have any major difference in terms of lactate clearance, which is an independent predictor of outcomes in shock. But it was also associated with less limb ischemia, as you can imagine. And there should be a Kaplan-Meier curve here as well, looking at outcomes using smaller cannulas versus largest cannulas, and it doesn't have a significant difference starting with a smaller cannula. So I think one of the things I believe for ECPR or crashing ECMO in the cath lab, starting with a 15 French cannula should be the way to go. You're doing things emergently, and it's usually a growing complication that happens the next day or limb ischemia, and that's an independent predictor of mortality. Both those things in someone in ECMO. Then is it too much oxygen a bad thing or a good thing? What do you think about that, Jen?
I think it's a bad thing.
Okay.
I think you could also I think it's along the same lines of using like excessive FiO2 on ventilation.
Yeah, exactly. That's what it is. So again, from this same registry, they looked at target levels of oxygen, and with these things, you can have a PO2 of 300 if you want to, right? So, but that doesn't mean that helps, and that's been looked at. So actually having severe hyperoxia was associated with worse outcomes. So if you crash an ECMO in the lab, you should get two things. So you should get, what's your first thing? What's your other axis that you should have, Jen?
Your B.
Okay, so you have A and B, but let's say the cannulation, you finished the cannulation.
Your distal perfusion catheter.
Okay, that's one. And the other one?
In the ABG, in A line.
From where?
Typically from the wrist, right?
Which wrist?
The non-A side.
Right.
So,
Why is it right? Not
Harley Quinn.
oh,
or-
the
Okay, good. So you need two things. You need possibly a distal perfusion catheter, and you need a right radial sheath before the patient leaves the room. And that's for two things. You need to check normoxia, and the quicker you resolve this, the better the outcomes, and not brain injury, other things that happen with immediate hyperoxia. And then you have to check for north-south syndrome or the Harlequin syndrome, which we'll touch a little bit about that.
Is that
I
what we
thought,
do?
no, we never do that.
Yeah.
The few I've seen, I've never seen it. My first complication here was like a month in, crashed on ECMO. It was horrible. It's a PA rupture, and if that, we just want to welcome Dr. Davila to the room. And so we crashed on ECMO, and that was horrific. We did it, and the patient was developing north-south in the room. So, and she came off ECMO, but I've never seen it, and I always try to push for it when I'm around. So I thought I had something about north-south syndrome here, but since you mentioned it, Ravi, why don't you tell me what that is?
So from my understanding,
Yeah.
basically, when you're, not when the LV is not venting enough, initially, you don't have any LV venting, but when the heart functions and recover, you start getting these different mixing pools. And you worry about distal lymph perfusion, especially depending on where your mixing pool is. And that's why a distal right radial art line, which bypasses the mixing pools, will give you an idea of how you're, oxygenating and stuff. So,
All right, yeah, so that's clear. So if you have an ECMO, the ECMO pump that is pumping blood against the heart, right? You should identify what they call the mixing cloud. Where is the mixing cloud? Where is the flow from the ECMO mixing with the flow from your heart? So I saw the angios for someone crashed on ECMO recently that needed a PCI on ECMO. And if you see those angios, you can see the mixing cloud. You see contrast staining in the cusp, right? So that's your mixing cloud. You're right there at the heart. That means that heart is not being vented. So probably that patient needed venting. But sometimes the native heart recovers immediately. And now your mixing cloud moves distally, right? And that could be even after the great vessels, meaning that now you're perfusing the brain with not oxygenated blood because you're bypassing that through the ECMO circuit. So that's why the Harlequin syndrome or north-south syndrome. If that's the case, and the way to measure that is by getting ABGs from the right radial, you're getting hypoxia on the right radial despite your ECMO oxygenator, that's north-south syndrome. And that needs to be fixed. And that's
Do you think that that's a reason that we have so many strokes?
yes. So there are two hypotheses. That one is that one, and the other one is the hyperoxia.
Should we talk about this?
I think so. I would love, yes, I think so.
I mean, I think like I've had several patients that I've been following or whatever that have
They all
had
stroke
ECMO,
out.
they all have a stroke.
Yes. So, but these are hypotheses. Remember, these are flows, they're 4.5 liter flows but yeah,
It just seems like
it
possibly.
is possibly one of those things. So
Sorry.
it's all right. So I have some ECMO here for, I hope, I don't know if John's still on, but I have some ECMO cases here in structural heart diseases, which are also very interesting. This is someone that came in when I was a structural fellow on with a acute and chronic bioprosthetic valve degeneration with severe AI that crashed on ECMO. So what would happen if you put this patient on your regular VA ECMO?
gonna make it worse.
Severe AI.
You're gonna make it worse, right? So now you have LV tracing, PA tracing here, almost systemic. So all the flow, all your mixing cloud is like in the LA. So you're pumping all that blood back into a dysfunctional bioprosthetic valve. So it's going back into the LV, back into the LA. So that makes it worse. How do you fix that?
The OR.
Go to the OR. Okay. They usually don't take them. but
You bent the LV.
You bend the LV. How do you do that?
Do the LA, like tandem hearts.
Tandem, right? Because like you can't.
Tandem nobody uses tandem now anymore. But so now you can configure that ECMO circuit using what's called LAVA ECMO. So that's left atrial VA ECMO. And I've been trying to poke John to see if we can do a couple of days because we've had cases that dysfunction. Is it sepsis? Is it the valve or whatnot? But I'll show you a couple of nice cases from here. And that's where the concept of venting the ventricle comes into play. It's been shown in observational data that venting the ventricle improves outcomes. Actually, in this particular study, which is the only study, venting with a balloon pump was better than with a CP, which gives you the concept of venting is what matters. It doesn't matter. Sometimes inotropes can do it, or mechanical venting will do it as well. So this is that LAVA ECMO that I was telling you about. So what you do is you get your venous cannula, a multi-stage cannula, across the septum. So you get a cystostomy and then you park that cannula, draining both the LA and the RA, and that way you get venting of the left side, especially in the setting of valve dysfunction, either mitral or aortic. And it's impressive what they do to the hemodynamics. This is one of the cases within fellowship. So ice guidance, cestostomy, and this is the balloon cestostomy. You park your wire in the left upper pulmonary vein, and then bring your cannula across. And that way I have some hemodynamics here. I thought I had hemodynamics here. But it's a significant, well, you can see here, there's a significant reduction in, no, this is from the valve. Here, so look at this wedge, from 36 to 4, as soon as you started the LAVA ECMO. And your mean PA, which can get systemic, right, dropped significantly to normal pressures. So some places, what they're doing for these patients is they go on LAVA ECMO and then let them rest for a day or two, making sure lactate clears, creatinine improves, liver function improves. Because as you know, every time we do a structural intervention, there are outcome measurements and things like that that we need to keep an eye out. But usually, if the patients turn around on LAVA ECMO, some places go ahead and then fix the valve. This is a case that I saw recently. I had nothing to do with this case, but so this is what we call a unicorn. So it's a fancy name for perforating a leaflet and then balloon tearing that leaflet. This is when we're concerned about coronary occlusion. So instead of doing what some people do called basilica, this is just get a balloon across. And Ahmed and John have done a couple of Batmans, which is the similar concept, but in the mitral valve. But this is using LAVA ECMO preemptively for these patients. But as you can imagine, as soon as you tear this leaflet apart, what's going to happen? You get wide open AI, and then you have to rush your valve in, get angles and whatnot. So some groups are doing this preemptively for high-risk structural interventions.
That improvement in wedge and PA pressure is because you're literally taking blood.
You're draining
You're
the LA.
draining-
You're draining the LA, oxygenating the blood, putting them back in. So you're pretty much taking over the heart, right?
Yeah.
Would LAVA ECMO also be useful in patients because these chronic heart failure patients who come in shock sometimes they have LV thrombus. So Impella, depending on who you ask, contraindicated. So LAVA ECMO being an option.
Yes, absolutely. That's another use for this.
And can we start doing this?
So these are a couple pictures. There are a couple pictures here. So, I mean, these are complex things, right? And so, I don't see why. I mean, I think, let's see how I phrase this. So I think it's important to get, percutaneous skills like all of you have to do some of these procedures, not only the actual mechanical circulatory support devices, but also the distal perfusion devices. Here, this was another one. This is a nice one too. So this was a case who on ECMO and venting who had STEMI, and then we had no access, like no radial, nothing access. And so what they did is they spliced a white connector, see this white connector here, into the arterial return cannula, and then had a dry seal and pretty much created a, what do you think this is? What do you use this for every day? It's a TUI, right? So thinking as an interventionalist for this thing is actually pretty neat because they created a TUI using a dry seal, and then through this on support did the PCI.
That's so cool.
Yeah, and then so the only issue I remember we had is And this was actually well, the issue we had is we didn't account for all this dead space. And I say we, because I wasn't doing anything, I was just holding the groin, but my intending, we didn't account for this, and then so the guy wouldn't reach. Yeah.
No, but
So we use a JL5 guy, you can see it here, barely reaching, airmail the wire, and then guy liner the whole thing.
Holy smokes.
But the neat thing was this.
Are there, well, it was.
So he patented
but
this thing. So.
like the TIG and the Jackie are longer catheters. I think they have guides too. I wonder if
I don't
they're
know.
120.
Yeah.
But
So I mean, I guess the point that we're trying to make, I think, ECMO will continue to. ECMO has been around forever, right? And it's been a surgical tool. I think there's some innovation around it where there's role for interventionalists to know how to deal with these cannulas and help out with these cases. These are other platforms. Okay. What else? What else you guys want to talk about?
So I'm just thinking back on like one of the patients that we had with really horrible RCA disease. I don't know if you remember, like Charlotte Healy, where we didn't have any means to support her RV. By the end of the case, she had developed, fulminant pulmonary edema, was, saying we just didn't have a way to vent the LV at the end of the case. Like, is there any sort of means to provide her our RV support? What resources that we have?
We talked about it in our faculty meeting, and I think for that particular case, I think we should get the surgeons to implant a Protect Duo, which is it's a 31 or 32 French dual lumen catheter cannula that goes through the IJ, and it will provide enough support to do that. To be completely fair, the data on RP Impella is not good, and unless it happens very acutely, I don't think it provides enough support to dealing with acute and chronic RV failure. So if that's the case, what I think we should do is we should get heart failure involved early on. Some providers are more aggressive than others, but I think we should get heart failure involved right away. And if we agree that this is acute and chronic RV dysfunction, talk to the surgeons for a Protect Duo. The thing with RV, and we've all seen it, right? Is let's try fluids, let's try the butamine.
RV is terrifying.
And then RV is
serious.
tough.
Yeah.
And remember, it's half of the heart.
Yeah, even for dealing with the ventilated patient with RV, it's awful.
So usually when we reach to that point, it's too late. Right? So that's the vein of our system.
Thank you, Carlos.
All right, so we'll do